Good afternoon. Good evening, everyone. I want to thank you again for joining us at PHEN, Prostate Health Education Network's Managing Survivorship meeting for May. Now, this is interesting because if you notice, I'm not in the treatment title today. This is going to be a very interesting discussion about exercise. But before we go any further, I'd really like to take the time to thank our sponsors. Again, the Dana-Farber Cancer Institute. We have Johnson & Johnson, we have Amgen, Merck, and Sumitomo are the companies that sponsor Managing Survivorship. So I wanted to thank you there. And also I wanted to thank our audience here and those who are online. We're gonna really learn something interesting today. So first, I'd like to start off with a kind of brief overview to kind of get you guys ready for what's coming down the pipe. Okay, so the reason why we participate in the Managing Survivorship meeting is because we want everyone to thrive. Now, what's interesting is this. If we think about it, we're at a crossroad, and you've seen this image before. You can either be in the 20th century or you can look at the 21st century. You can look at the 21st century. And in the 21st century, what's interesting is this, some key points. When we're managing survivorship, why is it important? Because early detection screening, not early detection screening alone, but we're talking about initial diagnosis and disease recurrence. That's one area. But also, we're talking about lifestyle. Your lifestyle can influence whether or not you get cancer and whether or not your cancer returns. So I'm gonna lay the groundwork, and we're gonna talk about physical activity because a lot of people don't recognize how important physical activity is. Now, what's interesting is this. We have different ways of treating prostate cancer, right? You know, active surveillance, surgery and radiation, hormonal therapy, chemotherapy, immunotherapy, targeted radioligand therapy, precision medicine. But exercise plays a role in treating prostate cancer. It's interesting. So we're going to learn a lot about this today. But first, I want you to know, these are the terms that you're going to hear in the presentation today. ADT-induced muscle loss and fat gain. Now, this is the loss of muscle mass and increased body fat when you're taking ADT, androgen deprivation therapy, for prostate cancer treatment. Biochemical recurrence, because this is going to be a term you're going to hear a lot. And it really focuses on PSA velocity, PSA doubling time. We're not going to go into a lot of detail, but that'll be a topic we continue to discuss throughout this year. Cardiovascular disease, there's a risk factor. And there's a study, the Framingham risk score, and this is Framingham in Massachusetts. And it estimated 10-year cardiovascular risk using a gender specific algorithm. But we won't talk about algorithms, but we just want you to know that these terms are going to come up. Disease reclassifications in patients on active surveillance. Exercise intervention. Now, what you'll hear is something called HIIT. Now, that's going to be very interesting. Again, our speaker will cover these points. You'll hear about home-based, virtually supervised exercise training program, and that's what's extremely excited about these clinical trials that you're going to hear about. Then we roll into this area of the immune system. That's extremely interesting. How does the immune system play a role in cancer prevention or killing cancers and the immune system with exercise? And you'll hear about prostate cancer specific mortality and all causes of mortality. This is the number of deaths directly attributed to prostate cancer and the total number of deaths for any cause, respectively. And then cardiovascular fitness. So my question to everyone here and everyone online, are you an inactive individual? So why is that important? If you're an inactive individual, you don't exercise a lot. There's the association with obesity, abnormal cholesterol levels, suppressed immune response, hypertension, and then you're also an increased cardiovascular risk. And you normally, if you're not active, you don't really eat a lot of healthy foods. So what's interesting is this: exercise tilts the balance in favor of a strong immune system. And what you will say, you said, how is that going to work? And that's what we're going to learn today. A good exercise regimen improves the number of functioning immune cells, because you heard earlier, immunotherapy, immuno-oncology, where your immune system plays a role in keeping cancers at bay. So I'll say it again, your immune system fights and kills cancers. And so what we want to do is, can we optimize the killing effect of our immune system? And the answer is yes. And the answer is with exercise. So when you have cancer, you can either be an exercising individual or sedentary individual. But what we're going to find out today is, if you're sedentary, then it has a protective effect against cancer growth. If you exercise, you can kill the cancer. So I'd like to bring up our speaker, Dr. Kane. So he's going to talk about not only exercise in relationship to prostate cancer, but he's also going to talk about a couple of clinical trials that are here at the Dana-Farber Cancer Institute. Dr. Kane?
Right. Oh, did it? You did already.
Oh,
Okay. Turn it on.
yes.
Oh, yeah. Thank you. Good evening, everyone.
Good evening.
Very nice to see you, whether you're joining in person and whether you're joining on Zoom virtually. I am very, very happy to be invited here today to talk about exercise. As Keith mentioned, that there are lots of things going on when you're doing exercise. Really, there's so much things we can talk about exercise, and we know that exercise is good. Who doesn't know? If anybody can say exercise is not good? No, everybody knows. But it is very crucial to know the why. We have a really clear understanding on why exercise matters in terms of cancer survivorship, in order to get ourselves up and do some exercise, and then we know what's going on in our body when you're doing exercise. So as you know, that there are many conventional prostate cancer treatments, but the goal with the exercise is not only to help your survival, but also have you or help you live stronger, healthier, and longer, which especially the healthier, stronger part, many other treatment can really do, but exercise can do. So I'm gonna really dive really deep into the most up-to-date evidence about what exercise does to our body, but also I'm gonna go over what we don't know yet and what we are really working on to know at this moment. So today, I'm gonna go over some of the benefits of exercise that you may know already, or some of them you might not know. And then I'd like to kind of introduce the guidelines that we have at the moment from the American Cancer Society and American College of Sports Medicine. And we're gonna kind of have a good ground information about exercise. And then I'm gonna introduce some of the more recent evidence that what we have to know about exercise, especially related to cancer progression and some of the important comorbidities. And then I'm going to introduce those 3 exercise clinical trials that's going on at Dana-Farber. So why do you have to do exercise? It's very obvious to know that there's many treatment stages or survivor phases that you know. From diagnosis, you receive surgery and radiation, and then hormonal treatment, and there are other systemic treatment. This is a very rough example of one person's cancer trajectory. And each of these treatment or any phases of cancer survivorship, there's a need for addressing various treatment-related side effects and also cancer-related related concerns that I'm going to talk about in terms of the benefits from exercise. One of the most or widest studied in this exercise and prostate cancer area is from what we observed for those who are receiving hormonal treatment. It's just mentioned about the weight gain or fat gain and muscle loss. This is a very obvious side effect from ADT. And there's multiple meta-analysis that are showing that exercise can reduce the fat mass and increase the lean mass. Lean mass means that it's the body mass, the whole body mass, excluding your fat mass. So most of the lean mass includes or consists of muscle mass. So for example, we are looking at this left figure. Approximately between, I guess, 3 to 4 months, or even between 4 to 5 months of exercise training, specifically focusing on resistance training, like biceps curls or squats. Those, if you are participating in that exercise for about 4 to 6 months, they observed about 0.5 kilograms of body muscle mass over the time. It might not look like it's a lot of improvement, but you have to consider that if you don't do anything during ADT, you will see the decline in your muscle mass. That's the default. It's not going to stay the same over the course of ADT. So the improvement in your lean body mass is very substantial in terms of during ADT. And fat mass as well. When you look at this figure on the right side, it's about 0.6 kilograms of fat loss after 4 to 6 months of exercise. So this is very substantial improvement that's been found over the years of research, and actually one of the most strong evidence we have. And another one is it's more obvious. I'm gonna go through some more obvious outcomes more quickly, so we can improve our cardiopulmonary fitness, but this is one of the most obvious measure or most objective measure of measuring someone's fitness. If you talk about how fit you are, this is the measure, we call it VO2 max, how much oxygen your body is using. And exercise, especially with the aerobic exercise, can improve the cardiopulmonary fitness over time. It's been found from multiple randomized control trials. Also, during the course of cancer survivorship, many cancer patients experience poor quality of life. And exercise has been found to be improving their quality of life along with other psychosocial outcomes, including anxiety and depression. How about some of the local treatment for prostate cancers, for example, surgery or radiation? Many patients are experiencing some urinary incontinence and sexual dysfunction. What does exercise do for that? So there's on the left side, when you look at this meta-analysis, it's hard to, it's really smaller, but in short, exercise, when you're doing specifically focusing on your core muscles, we call it Kegel exercise sometimes, or pelvic exercise, where you're lying down on the bed, trying to push the floor with your lower back, and then you can contract your muscles around your core. When it's given for about 3 to 4 months, and then they can improve their urinary incontinence or reduce this type of symptoms. And then there are more than 20 randomized controlled trials looking at how exercise can improve potentially sexual dysfunctions that prostate cancer patients are experiencing after their local treatment. And then about 40% of trials reported that there's a significant improvement in their sexual function in the exercise group. It may not be the majority of the studies, so we have to investigate more on this topic, but there's a more clear trend that even in the other studies, they're showing that there's a tendency that exercise can help with the sexual function. And this is more of the more recent studies as well. And we are seeing some of the evidences in mice. So when exercise is given during the radiation therapy, it appears that exercise can help the effects of radiation or radiotherapy responses. How does it work? When you look at this figure on the right side, here we go. One of the reasons how it works is when you do exercise, there's a vasculature around the tumor. Exercise helps dilate or expand the vessels around the tumor. It helps deliver the radioactive components to the tumor cells and help increasing their radiotherapy response rate. This is one of the mechanisms that how it works with the exercise, with the radiation responses. So these are some of the evidence that we have, but there are obvious benefits of exercise that I just talked about. But to get these benefits, we believe that there's more wide, broad physical activity guidance. How much should I do? Well, this is quite, when you look at it, it's very, very broad from the American Cancer Society. What they say is be physically active. For some people, if they are 100% physically inactive, this is very important. You have to get yourself out of the bed, out of the chair. You have to be active. That's the first step. But also, there are many people who are already active. So these are some of the guidelines that you have to engage in more than 150 minutes to 300 minutes of, it's important, moderate intensity. we are not talking about walking. To get some of those benefits I just mentioned, or even some of the benefits I'm gonna mention in a moment, is coming from at a certain or over a certain levels of physical intensity. So when you're walking, if you're not doing any exercises, walking is fine. But if you want to actually get those benefits, and then you have to meet those guidelines and then be more active, and then you can measure, actually quantify how much you're physically active you can do. And then when you think about what's the moderate, then the easiest way of kind of explaining, I'm usually when I see patients, when you do exercise, then you have to be sweaty. And when you're doing moderate intensity exercise, you can hardly talk. So that's some of the indicators how you are doing it moderately. When you're actually watching in your heart rate, then you will know also that it's more than 70% of your heart rate is needed to be moderate intensity. And there are other guidelines that's published in 2021 from American College of Sports Medicine. It's the largest exercise science body that releases these guidelines over the last more than 10 years. And some of these guidelines are very specific. And then one very obvious one outcome that has a very strong evidence is a cancer-related fatigue. And then they have aerobic exercise and resistance exercise and how much you can do to get these benefits. I mean, obviously, I can share this slide and you can look at this and then you can see what specific exercise are needed based on the clinical trials we have done. And then you will know that, oh, these might be needed to get these benefits. So I'm gonna kind of reiterate why you're doing exercise. And one of the reasons is you have to be purposeful. Every patients are going through a different side effects and different treatment journey. You're feeling extremely fatigued, but otherwise you're okay. But then you have to focus on, okay, what should I do to improve my fatigue? Physical function, for example, here. And then you can look at this. And then there's anxiety and depression. It's interesting that we don't have enough evidence that resistance exercise can improve their anxiety and depression. Most of studies are showing or using aerobic exercise. So you can look at this as well. And we don't have much evidence that resistance exercise can improve anxiety. So I can probably do more of aerobic exercise based on what we know for now. For example, and then lymphedema is more relevant to breast cancer, so you can ignore this. And then also bone health is very important, right? So especially during ADT, your bone density is likely to decline. And then when you do some of the resistance exercise, particularly, and then you can improve bone health in this sense. So these are some of the other evidence that we have compiled over the last decade. So I kind of set the base of what we know about exercise. And Dr. Crawford mentioned about the exercise and survivor, exercise and immune function, exercise and tumor itself. And those are very emerging topics that we have not really investigated in prostate cancer patients. So we can't answer those questions yet, but that's what we are going towards and really wanting to answer. That exercise actually might be a treatment, but we can't answer that question yet. Because these line of thought that exercise might be helpful for cancer progression or recurrence is based on some of the epi studies in the beginning. Dr. Stace Canfield and then Jun Cha, and they mentioned in November last year about the physical activity and diet and survival. And this is one of the outcomes we have seen that when you're doing exercise, this is the prostate cancer specific mortality, meaning that you're dying of cancer. So when you look at the prostate cancer, and there's about 30% reduction in your mortality of prostate cancer. And then when you look at the all-cause mortality for prostate cancer, there's about 40% reduction in the risk of dying of any cause of death when you're physically active. So more specifically, this data is mostly looking at those who are physically mostly inactive in the cohort versus who's mostly active in the cohort. And then there are other studies that are showing that I didn't put it here, but there seems to be a dose-response relationship in that, meaning that if you do more exercise, you can get more benefits. And this is also particularly on active surveillance patients, because I found it's the most recent study that's published in prostate cancer journal, that this study has been showing that, so this line, the straight line here is the sedentary patients who are on active surveillance, who's getting treatment or their risk of prostate cancer progression is getting higher. So sedentary people have a higher risk of disease reclassification. The more you're active, the less likely that you're going to have disease reclassification, meaning that you may stay in active surveillance if you're physically more active. So these are some of the epidemiological evidence. How about animal studies? I'm going to just show you one example here on the left side. This is an animal that's given a prostate tumor from the human sample. And then this black bar on the left here is the sedentary mice. They're just given food, but they didn't do any activity. But this gray bar on the right here is the exercise mice. And then this is 14 days after they started doing either exercise or sedentary. There's a significant differences in their tumor weight or tumor size. And then even 28 days after, it's almost the day they have to be euthanized. And it's more than twice more than twice higher chance of the tumor weight is different or higher in the sedentary group versus exercise group. This is one of the examples. And then there are a number of similar studies. It's not specifically for prostate cancer tumor models, but many cancer tumor model animal studies with the exercise intervention have showing that we are compiling all this evidence and looking at these outcomes, and exercise seems to have more consistent benefits of reducing tumor volume. But how does that work? Why does that happen with the exercise? It's not a conventional treatment. It's not a surgery. It's not a radiation. How come it happens? And there are a number of different mechanisms that can explain. There's so many things going on physiologically when you're doing exercise. And there's one particular mechanisms that are gaining a lot of attention, that when you're doing exercise, epinephrine is it's a hormone that's released during exercise. And then this particular hormone helps your immune cells into the bloodstream. And then these little things are immune cells, specifically is natural killer cells. Our body has this function to kill those tumor cells and identify and kill them. These cells are more abundant in your blood when you're doing exercise. And then there's a particular also hormone that's released from your muscles. When you contract your muscle, there are certain proteins or certain chemicals are coming out of your muscles, and that they can help your immune cells getting into the tumor cells. So these are one of the mechanisms that is explaining how exercise can reduce the tumor cells and tumor sizes. Oops. So given this type of mechanisms, I conducted a clinical trials about like 5 years ago. And I was curious about how exercise can help this type of cancer progression in active surveillance patients, but in human. So by the time we have no studies or clinical trials that are looking at how exercise or the effect of exercise on biochemical progression of prostate cancer in human or in cancer patients. So what I thought is if you are doing exercise, I'm not going to go through everything, but there are many biological pathways. I'm an exercise physiologist, and there's so many things going on when you're doing exercise. There are many pathways that can help reduce your cancer progression. And these may help, I showed one of the epi studies, they can stay longer on active surveillance. And it can interpret it that they can increase their survival, or cancer reduction in cancer progression can directly also improve their survival too. But this was kind of my conceptual model that I think can work with exercise. And then, so eventually I recruited about 52 patients in total, and they have 96% adherence, meaning that most of patients were able to do exercise. It's a 3-month exercise intervention. I'm going to show you in a moment. A very high adherence rate. So more specifically, the exercise program itself was I implemented high intensity interval training. I mentioned about the intensity, moderate intensity, high intensity before. It appears that the higher intensity you do, there's a higher immune function or higher response in terms of increasing your immune function in your body. So I implemented some of the high intensity training, and they were walking or jogging on a treadmill for 3 times a week for 12 weeks. And this is what I found. The prostate cancer specific antigen, PSA level, was reduced in this blue dot is the exercise group, reduced in the exercise group versus this orange dot is control group, approximately 1.1 microgram per liter. And then prostate cancer PSA velocity, which is the speed of changing your PSA, was about 1.3 microgram per liter reduction in the exercise group. This is a very, very interesting finding that we have not seen in patients before. And this was translated from the epi studies we've seen and also in the animal studies. So it was very exciting. And we were even looking at the cell lines. We were specifically looking at each cell line that they might increase or reduce the chance of cancer progression. And then exercise group has about 5% lower changes in a cancer cell line proliferation or cancer cell line growth. And I was looking at the cancer cell or NK cell. It's one of the immune cells markers, and I see there's more immune cells in your blood in the exercise group compared to the control group. And then their cytotoxicity, which is the ability. So even if you have the same number of immune cells in your body, their functions are different. Maybe some of the immune cells are not very much active, and they are not really finding and killing cells or tumor cells. But the cytotoxicity means that their ability, their power to find and to kill the cancer cells, and indeed has increased in the exercise group compared to the control group. This was a very exciting finding that's published recently. Well, it's not immune function, and there are other benefits I found in the same study that patients have significantly lower degree of fear of cancer progression. Also, when you think about the high intensity exercise, many patients, what I found is that they think that can I do that? I'm a little bit afraid of doing this high intensity exercise. But after the 3 months of prescribed one-on-one supervised by the exercise physiologist, they found it, actually, it's very feasible. You saw that 96% adherence. So maybe if you can talk to actually exercise specialists, they can guide you how to actually do that rather than being feared and then not doing it. So it was what we found, that they are more motivated and then they think it's more enjoyable and then more feasible. So yes, Dr. Crow.
Yes.
Yeah.
I want to stop for a second and I'm
Sure.
going to ask some questions before we transition on to the clinical trial.
Okay, sounds good. Yeah.
All right.
Back or
Yeah. So what we want to do is, you're taking in a lot of information. And I wanted to stop here for a moment and then ask if you have any questions about what we found, what he's found, his work, or anything that you have questions before we move on to the clinical trials. I'll take a few questions if anybody has questions.
I'm just wondering about patients who are on cardiac meds. I'm just wondering about patients who are on cardiac meds. So do you get a clearance from a cardiologist or get a baseline echo or EKG? I mean, that seems to be an issue.
Sorry.
Or you exclude, I mean, they can't exclude them because a lot of people are in that age group that.
So maybe I can reiterate your question. So there are patients who have preconditioned or they have some cardiovascular condition already, and then you're not sure if they can do the exercise or you're not feeling safe.
Right. Maybe they have
for them.
cardiomyopathy, maybe
Right.
they have AFib, they are on medication. You can see what they are on, so you know what's going on, but.
So let me mention this first. So there is, for example, like 50 years ago, we have cardiac rehabilitation. We didn't have the cardiac rehabilitation. When they have something like AFib or cardiomyopathy, they are not allowed to do exercise. Right now, after 50 years, that's the first line of treatment after they have it. Meaning that we have a safe and then very feasible programs that they can start doing the exercise. So there are particular programs they can join, and then exercise physiologists can understand their conditions. And then it's probably, if you want to do exercise on your own, you might be more reluctant. But I would definitely ask you to talk to the exercise specialist. And then there's very strong evidence and then very strong programs they can start the exercise with the conditions. Hope that makes sense?
Oh, you're right, because cardiac rehab starts immediately after
Right.
people have some kind of an event, and they're highly monitored. But the question is afterwards, but you're saying
Yeah.
that you
So,
can provide for
Excuse me
safe.
for interrupting, Dr. King.
Mhm.
If, is anyone else have any questions? I think that was it. We'll
Hello.
take one more, and then I'll have Dr. King come up and finish and focus on the clinical trials.
Yes, I have a question. I know you're going to talk about the clinical trials, but my question is, if you're not eligible for the clinical trials, can you still get a list of those exercises so you can do them on your own?
That's a really good question. We do not have that system in place right now, but that's a really good point. And if you have, I guess, the willingness or try, and if you can participate in this, in the research or clinical trials, I highly encourage you to consider. But if it's not available, there are other exercise programs that are out there. Dr. Crawford will be introducing those links
Yes.
Later?
Yeah, we'll provide you with some links.
Right.
So you'll have access to, and remember, everything that we talk about today will be recorded. It's going to be online, available for you. And then you can always call us.
There are many out there you may not know already, but there are many programs available for you.
And that's going to be helpful because when you hear the clinical trials, then you'll see there might be a clinical trial that you can use, participate in today. Okay. And that means you're not coming in here every day. You may be able to stay at home. One more question before Dr. King comes back up.
I just wanted to clarify the number of days or the amount of exercise that would be required to see a positive impact on if you're under active surveillance?
That from that particular study, we did 3 times a week for 3 months, right? And then we didn't compare any other programs. We don't know specifically like 2 days or 1 day. We don't know if they could have been effective, but that's one of the studies that are kind of exploring these outcomes. And we, for now, can say that maybe 3 times of exercise at a higher intensity can reduce or can get those benefits. That's what we may get those benefits. That's what we can say for now.
It was from 28 to 40-something minutes, you said?
Yes, exactly. So 28 to 40 minutes. So it's more progressive exercise program.
All right, thank you.
All right. So we're now going to move on to the clinical trials. And I think you're really going to be excited about what he's going to talk to you about, because this is, if you live in the Boston metropolitan area, you'll be able, go ahead.
That's just
Okay.
Is it the 5 minutes? All right. So, yeah, it is very exciting that we have some trials that's going on at Dana-Farber. I wanted to mention that this may not be applicable for everybody because there are certain criteria, just like any other clinical trials, but there are certain studies that we are running that I'm very happy to share. Just really briefly, these are the 3 studies, and then I'm going to go over one by one really quickly. So one study is focusing on patients who are on active surveillance, but we are this time focusing on Black men with prostate cancer. And then we're primarily looking at the biochemical progression, just like I showed you. And we're recruiting from Dana-Farber, BIDMC, and then Brigham Women's Hospitals. And there's another study called POWER study. These are patients who are receiving androgen deprivation therapy. And then we are trying to looking at the benefits of exercise on reducing the cardiovascular disease risk, as mentioned, the Framingham risk score. And then there's another study. The other study is a THRIVE study. This is for prostate cancer patients receiving chemotherapy. And we wanted to see if exercise is feasible or not. And we're looking at their physical activity levels. And these studies are particularly focused on racially minority cancer patients. So for REMOVE study, so this is a team of members in the team in the study. And I don't want to go through all this background that we already know, but we found that exercise may reduce the cancer progression, especially as shown in the biochemical outcomes. So we want to look at these studies or outcomes specifically in Black men with prostate cancer who are having a higher risk of cancer progression, and it's very legitimate to investigate in these patients, specifically focusing on this patient group. And we are recruiting 34 patients for each group. One group is going to the exercise group immediately, and then we call it, the other group is a wait list control, meaning that this group is going to receive the same exercise program after 3 months. So technically they're receiving the same program, but it's more like right now or 3 months later. And then patients will be receiving some of the compensations for participation. And the eligibility is patients who are seen at Dana-Farber or BI or Brigham. And then they are diagnosed with the localized prostate cancer, and they can self-identify as Black. And they have been initiating or already having been undergoing active surveillance. It doesn't matter if you are on active surveillance for 1 month or 10 years. So anyone who's on active surveillance can be eligible. Then exercise program is 3 months long, and it's home-based exercise. So this is something that we are trying to implement in terms of patients' acceptability and feasibility, because as I know, there are many patients who are not living around Boston. Coming to Boston, Dana-Farber campus can be very challenging. So we kind of tweaked our program in the past and try to make that more feasible, more accessible for patients. So we'll be technically providing exercise bike to their home at no cost. And then they'll be doing a one-on-one Zoom exercise sessions, each patient. It's going to be 3 times a week. And then intensity will be moderate to vigorous. And one session will be approximately 1 hour. And then exercise bike you can keep even after the exercise program is over. It's going to be yours. And obviously, we're looking at these outcomes, including prostate cancer biochemical progression, and then other immune and other biomarkers and their fitness and function, and some of the patient-reported outcomes like anxiety and quality of life. Should I receive questions?
Yeah, we'll
Mr.
answer
Point?
questions afterwards.
Afterwards?
Yes, I'll let you get through all of them.
Okay, good. And then the second study is the POWER study, looking at the effects of exercise on cardiovascular health in patients with or undergoing ADT. And it has been a concern, or has not been really addressed in the past, that some of the ADT or hormonal treatments are increasing the risk of cardiovascular disease. And we thought that exercise can help from many other studies, like in the cardiovascular patients, exercise can help reduce those risks. And then this is how we rationalize our study in the beginning. Now we are recruiting in total of 62 patients. Sorry, Jerry, I think I can just look at this. So similarly, with the REMOVE trial, there are 2 groups. One group is exercise group, the other group is usual care group. I think I can just do it. Thank you. And I mean, we put it usual care here, but they are the same as like a wait list control group. So they'll be receiving the exercise group, whether or not you're exercise or usual care. So the usual care group will be receiving, after 4 months of intervention, the same program. So we are recruiting patients who are diagnosed with prostate cancer, either localized or advanced. And then they have to be receiving ADT at least 1 month. And then they have to continue their ADT at least 4 months at the time of recruitment. And the exercise program is slightly different. So this exercise program includes aerobic, not only high intensity interval training, but also it has some resistance training together. And then intensity will be moderate to high, and then same 3 times a week. And then there are 60 to 70 minutes per session. And similarly, exercise program will be done virtually one-on-one with the designated exercise physiologist. And also, very similarly, exercise equipment will be sent to your home. And this study has bike, and then blood pressure monitor, and then there are some dumbbells that will be sent to your home as well. And then, oh yes, then you can keep those exercise equipment even after the program as well. And obviously, we're looking at those cardiovascular risks using biomarkers, and then their physical fitness levels and body composition, and then also patient-reported outcomes as part of the study. And then the last study is the Thrive study. So I'm gonna just skip this and for the sake of time. And the study has 3 groups, this study. So one group is a supervised home-based exercise. And as I mentioned, it's quite similar that they will be given one-on-one exercise sessions online. There will be 45 patients in each group. And then there's unsupervised home-based group. And then these patients will be getting a phone call or phone call once a week over the course of the intervention, and they'll be given the exercise program they can do themselves at home. And there's another group. The other group is the tension control group. They'll be given this stretching exercise program, and then we are measuring their physical activity levels. And unfortunately, we don't have capacity of doing same interventions for every group. So every group will be receiving different interventions. So some of the patients are concerning that, oh, I want to be in the exercise group or the supervised exercise group, but this is a randomized control trial. And then your participation is very important for us to know the effect of exercise, and control group, attention control groups is very important in the study for us to answer those questions. So even if you might not be in the exercise group or whatever you want to be in, it's randomized, and I hope you understand this is the nature of randomized trials. And this study, we're recruiting multiple cancer types, but we recruit prostate cancer patients who are self-identified as Black. And this study is also recruiting patients who are self-identifying as Hispanic. And then whoever starting initiating chemotherapy within 4 weeks, and they are eligible as well. And then one of the criteria that we have is that they are patients with overweight or obese patients who will be eligible. And there's more specifics I mentioned. Then they exercise either supervised or unsupervised. They'll be given an exercise bike and the resistance bands. Primarily, we are looking at physical activity levels for this thing. And this is not so necessary. And there's some contact information for those studies. I can just skip this.
Thank you, Dr. Kane.
Thank you.
Thank you, Dr.
Oh, sure.
So what we want to do is, first we want to again give Dr. King a round of applause. What would be said? That's exciting. That now we have clinical trials, and some of you get to keep some of this stuff. So what I wanted to do is, you heard from the doc who did the studies, created the clinical trials. I want you to hear from a patient who is a trainer for activity every day. So it's going to be important. Just listen, and I want to bring on Mr. Will Thompson. He's out in California, sunny California, where he can exercise every day. Mr. Thompson, you have to come off of mute.
Okay.
So what I want you to do is tell them about yourself, tell them a little bit about your history, and then tell them what you do. And I think it's important for people to understand how exercise played a very important role in helping you.
Alert from calendar. Write a page today. Terminal 2 miracle.
Okay, ready?
Hold on one second. Let me put this on focus. Okay. So thank you for having me. I am a cancer survivor myself, as well as a certified medical exercise specialist. I've been a certified exercise specialist for a long time. And I originally started doing it because of having been in a couple of car accidents out here in LA. People don't drive very well. And so I had to do rehab on my back. And the more I learned, the more I wanted to apply it and be able to help others. And fast forward to 2017, I went to get a PSA test and found out after I had been denied a PSA test some years prior that I should have gotten those results or made sure that I got tested because my PSA was astronomically high. PSA was 5,846 by the time I was diagnosed at age 53 and was devastated. And I was told that after further examination, after I got a biopsy and some scans, that there was nothing they could do. Best case scenario, I could get chemotherapy to slow the progression of my disease. I had what was classified as a T4 tumor, which means that even though I hadn't metastasized, it was now interceding into other organs, which would require those organs to be removed if they were to try to surgically remove it. So, my plan had been initially, if I could get ahead to, if I had a PSA of 4, I'm like, oh, I'm going to work out and eat better. And after being told that there was no real curative treatment for me, I was like, what else? What else is there for me to do except keep working out and eating better? So I made some drastic changes in my diet. I was working out, but I looked at some studies and the doctor was very, covered a lot of the same findings that I found, that people who do cardiovascular exercise do better. And I wanted to do better. So every morning I live, luckily, as the doctor said, I live in LA and I live at the bottom of a canyon. So every morning I would get up at 6 o'clock in the morning and do like a 3-mile hike. And my place of business is also where I reside. So I assumed to come down and do the hike, do an hour weights, which is really, really important, especially when you have like very aggressive cancer and you like prostate cancer and you're on these hormone blockers, the ADT, the androgen deprivation therapy. It is really important. Because even with the exercise, I did run into problems later with the hormone blockers with a rotator cuff tear because, as the doctor mentioned, that we lose bone density with the lack of testosterone, we also lose muscle density with the lack of testosterone. When you're on ADT, it's not like a lack of testosterone. It's like your testosterone, mine was below 10. And I was starting at a testosterone level of like 700. It might have been 800. It was very high, which was one of the reasons my PSA levels were out of control, because that testosterone was leading to cancer. But I found with a drastic change in my diet, which actually for the first year I was on a raw vegan diet, which fortunately allowed me to go from needing to have chemotherapy to not needing to have chemotherapy in 10 days, which I know sounds impossible, but all my medical records have been reviewed by a clinical study at Harvard called the Harvard NEAR study, which is the network of enigmatic exceptional responders. These are individuals like myself that have had end-stage cancer that have achieved remission without curative care. And so in those 10 days, up every morning, 6 o'clock, get up, go hike for an hour, get in the gym, have a smoothie. Actually, I would have 2 smoothies, and then I'd have like a raw vegan wrap and a superfood salad with a lot of beans, chickpeas, lentils, making sure that I was getting adequate protein, which is really important, because a lot of people do, when they get on these vegan programs, and especially raw vegan programs, are told that protein is not important, and that couldn't be farther from the truth. We need one of the key things, especially when you're fighting cancer and the disease, is immune function. And so with that, you need protein. You need protein to build white blood cells. And so it's very important that you understand when you're changing your diet and applying nutrition, that you know what foods have protein, what foods don't have protein. There's a lot of misconception. And it's very important that you get moving, get your cardio in, the more the better. And with especially on the ADT, androgen deprivation therapy, resistance training is really important.
So, Mr. Thompson, quick question.
Yes.
I didn't mean to cut you off. For those in attendance and those online, what's the takeaway? What is your takeaway about exercise?
For my situation, it is a key. It's it's a synergistic process with your body. It's just like, if you want to live, if you want to have your body function optimally, you gotta take care of it. It's gotta move. It can't be sedentary. Your heart, and that's, especially with these medications and treatments, there are a lot of side effects. And if you want to minimize the side effects, and another one of the issues, medications that they usually, a lot of the prostate cancer patients get is Flomax, which helps with enlarged prostate. Fortunately, I didn't need it, but I was on it. I was prescribed it. And that will make you, really tired. A lot of side effects from a lot of these medications and treatments, radiation will make you very tired. Flomax will make you very tired.
Taking away is that you want people to make sure that this is something that you can do in addition to your medication.
It's integrated. All this is part of what should be considered an integrative program. You want to, it's not you want to be able to function and allow. I was fortunate enough not to need to have chemotherapy, but I believe the doctor was talking about the studies that have been done with chemo, and he mentioned how with cardiovascular, especially with cardiovascular exercise, it increases blood flow, so it allows the the pharmaceuticals to get better delivery to the cancer cell.
Okay, so how old are you?
I will be 60 this Sunday on Mother's Day,
You were diagnosed when?
December 14th, 2017,
So how old were you when you were diagnosed?
53.
What's that? 53? Okay, all right. So now we have a prostate cancer survivor who exercised, and you can understand how it impacted his life. What I want to do is, and we're going to try to balance out some of the questions, but I want to bring in Dr. Smith because I wanted Dr. Smith to kind of add, in addition to the exercise, I want people to understand about advanced stage prostate cancer and metastatic, non-metastatic, and metastatic castration resistant.
I got one question.
Oh, we have one question.
Yes. Bill, this is Tom Farrington. How you doing?
Hey, I'm good. How are you, sir?
Good, good, good. Bill and I have been talking, I think, since he was diagnosed about 7 years ago. So we've spoken many, many times, and it's so
Yes.
good to see you doing so well. Can you tell us how you're doing today relative to where you were when you were diagnosed, and how much do you attribute to your exercise and dietary program?
Oh, I attribute, I don't think I would be here if I hadn't done, from what every doctor I've talked to has told me that this has never happened before. As I mentioned, I'm in the NEAR study. I'm one of 2 prostate cancer patients in the Harvard NEAR study, which is the network of animatic exceptional responders. I've never heard of a person who was told that they that had end-stage cancer and needed to have chemo and then didn't need to have chemo, and then went from not needing to have chemo to being in remission in about 4 months. I went from May 2nd, I was in remission. I've been in remission ever since. In February, I had a what they call a circulating tumor DNA test. I didn't even know that I had this test until I went through my paperwork later, and which that looks for the circulating cancer DNA in my blood. So this is 6 months on a raw vegan diet and working out. And I was on Lupron for a year, had some very unpleasant side effects. So I stopped that after the first year. But I talked to a researcher recently, and he told me, along with some other doctors, that you don't get the kind of results that I get with Lupron. Apparently, again, my treatment was not curative treatment that I received. It was palliative. It was supposed to just make me comfortable, but I was already comfortable. So I was so disappointed when I found out that news, but I'm glad that I, took the initiative to take that extra step.
And what
And,
did you say today?
say it again.
What is your PSA today?
My PSA today is like 1.
So you went from 5,000 to 1.
5,846, yeah, to 1. Pardon? And I've had, in the last year, I've had 'I've had 9 circulating tumor DNA tests.
Excellent.
Basically a liquid biopsy to make sure that there's no, and actually I had one done, the first 8 were done by this company called Signatera, and then Signatera uses a more sensitive test, this company called Personalis, that they use to basically make sure that they're not generating false negatives or false positives, and that was negative also.
Fantastic. I might also point out that William is in sunny California, but he is a Boston native. And I think it was the Boston winters that prepared him for this journey. So thank you for being with us, Bill.
Oh, thank you for having me.
Thank you, Bill.
Got another question?
One more question?
Yeah, you mentioned that protein was very important. Is there a point where too much protein, there's too much protein, or can you have too much protein, or, I know it's important, but can you take in too much protein that could be harmful?
Yeah, I mean, it depends on your protein source. So my diet was all plant-based protein, but well, I would say, no, it's all from whole plant foods. So one of the issues with protein, especially animal protein, is it increases IGF-1, which is insulin-like growth factor. And insulin-like growth factor, really good for building muscle. Unfortunately, it's even better for building cancer cells. So my protein, I was taking in like 35 grams of protein from whole plant foods. When I deviated from doing that, when I used the plant protein powder, which is a plant, protein concentrate, my tumor slowed in its shrinkage. It didn't go up, but it didn't. I was like the first 4 months, my tumor shrunk by 80%. When I went from my urologist to my oncologist, from my oncologist to my urologist, they were like, "Oh, wow, this is really good numbers, but you have this, this mass that's inoperable. But while you're here, let's take a look." And when they took a look, they saw that my tumor shrunk by 80% in 4 months. So I was under the assumption that 1 more month, I could shrink it 100%. Unfortunately, I wanted more muscle, and so I started putting this protein powder in my smoothies. And it slowed down the shrinkage of that last little shrinkage of my tumor. So I took it out of my diet. And when I did that, I had what's called an axial PET scan, which found no evidence of disease in where I once had this 11.5 by 8-9 centimeter tumor. All that was on the report said it resembled post-surgical scar tissue. So it looked like I had had surgery when I hadn't. And a year later, after my doctors were hounding me, it's like, "This has never happened before. You need to have radiation. It's gonna come back." I'm just like, oh. So a year later, I had the radiation, and twice during my radiation, they were like, "Oh, you had surgery." And it's just like, I'm like, "No, I didn't." It's just like, "Are you sure?" I'm like, "I'm positive." So that was very interesting. So yeah, definitely if your protein sources also, soy can have a high amino acid uptake too. So I don't eat a lot of soy, not because of the estrogen that most people think of, but because of the amino acid profile of soy that's been shown that if you have more than 3 servings of soy per day, it can actually increase IGF levels. So I'm very mindful of my protein sources.
All right. So thank you again. So now you understand why it's important to kind of balance academics and research with real world talk and background and information from patients inside our network. Now, what I want to do is we're going to be balancing time. I'm still going to be able to take some questions, but I want to bring in Dr. Smith. Now, Dr. Smith is just going to give us kind of an overview, and then we'll move on to some survey questions, but we'll also be able to ask Dr. King some questions. Now, remember something else too. If we don't get to your questions tonight, please email us, contact us, and then we can get these to Dr. King, and then we can pass that information on to you. All right. Same thing with Thompson. If you had some questions for him and we weren't able to get to him, we'll pass that on to him, and he'll give us some response. He's done it in the past, and he does it. He has a lot of information people may want to ask him about. Okay.
Oh, by the way,
yes, go ahead.
I was wondering, like I mentioned before, that I've been a certified medical exercise specialist. I also did, I'm not sure if I mentioned, after I achieved my remission, I did the University of Arizona College of Medicine, the med school course in cancer and nutrition, so that I could better understand why I was able to do what I did. And so everything that I, am sharing is not my opinion, but is based on the research that I've found to, basically explain what are the properties that allowed this to happen.
Okay. All right. So now we're going to bring in Dr. Smith. Jim?
All right, very good, everybody. Well, thank you all for being here. I want to also thank the support from our continued support from our sponsors. We're going to try to respect the time today because we really do value questions. So when you look at our website, PHEN, we're going to be under our treatment pathways, and this evening we're going to cover castration-resistant prostate cancer. There are two types of castration-resistant prostate cancer. The first one is non-metastatic CRPC, and the second one is non-metastatic CRPC. Basically, in the metastatic, we know that it has been spread to the cancer spread to lymph nodes, bone, bladder, possibly, and other organs. We also know that ADT, we see the testosterone level rising in spite of ADT. One of the important things is that ADT will continue to be the basis for treatment options as we look at castration-resistant prostate cancer. You see here on the screen the available treatments for the non-metastatic CRPC, and we talk about PSA doubling time. And PSA doubling time is the measure of time that it takes the PSA level to double. PSA doubling time is a useful tool to predict overall survival and the detection of aggressive cancer. Now, as we look at our website, as you see here, with a doubling time that's taken more than 10 months, we would continue on ADT, and then you would have also as an option ADT plus a secondary hormone. If that doubling time was less than 10 months or equal to 10 months, yes, we are continuing ADT, but we're adding apalutamide. We could be adding enzalutamide, darolutamide, or ADT and a secondary hormone. Again, all prostate cancer treatments are benefited by clinical trials. Can you return back to the next screen for me, Jerry? All right, go to MCRPC. Thank you. Now here, this is important. This is an excellent part of our website in terms of castration-resistant prostate cancer that has distant metastasis. We're talking stage 3, stage 4. And as you can see, Dr. Crawford has put together 4 excellent videos that we're not going to go through all 4 this evening because of time. But Jerry, would you please play the first video for me? I don't hear the sound. All right, well, don't worry. You can get that from the website. We're not going to try to take the time because it's so precious. But I will, if you can scroll up a little, I'm going to review it for the audience. So if you have metastatic castration-resistant prostate cancer, and Jerry, could you put that screen back up for me, please? Yeah, thank you. All right. The first group is group 1, and patients in group 1 have had no prior docetaxel or chemotherapy treatment and no prior treatment with a novel hormone therapy such as atebuterone, apalutamide, or enzalutamide. And so as you see, scroll up for me, Jerry, you will see that there are 3 treatment options. ADT with the first one, as I said, atebuterone, docetaxel. Then you have other treatment options such as Provenge, radium, and the other atebuterones with combination therapy. Can you please drop down to group 2 for us? All right, under group 2, these are patients that have had prior docetaxel or chemotherapy treatment, but no prior treatment with novel hormone therapy, such as the apalutamides and the enzalutamides. And in this situation here, the preferred treatment is ADT with the albuterol, with the enzalutamide, and with the chemotherapy, obviously docetaxel. But others are also useful, such as you see on the screen, the radium, and then the other different combinations have shown significant effectiveness. And third, you have what we call secondary hormone therapies. If you can scroll up for me, please. I mean, scroll down. I apologize. And so now we move to group number 3. Now, in group number 3, we have patients that have had treatment with a novel hormone therapy, but no prior docetaxel. And so here we add docetaxel to the ADT. Again, the other useful circumstances and that list of meds. And then the third opportunity, again, so scroll up to group 4, scroll down to group 4 for me. Now in group 4, we have prior treatment with docetaxel or chemotherapy, and you've got prior treatment with the novel hormone therapies such as apalutamide and enzalutamide. And again, as you see here, the preferred treatment would be both the chemo and the docetaxel, but then there are other options available. Most importantly is our website has excellent videos that will allow you to listen to what Dr. Crawford has laid out in terms of your treatment options. And I think there was a huge importance if each and every one of our listeners would go to PHEN path treatment pathways. And if you are diagnosed with castration-resistant prostate cancer, this part of our website is extremely important and effective in helping you work with your treatment team to make the clinical decisions that's best for you. Again, we went through this fairly rapidly today, but it's important for us to have you hear what we can and get some questions in the time we have with you this evening. Dr. Crawford. You're muted.
Yes, thank you. So what I'm just say is that this is very important because this is very important because people have stage 4 disease and didn't know that there were all these treatment options that are available to them. So we're going to dive deep into this next month. So, but again, for next thing I want to do is if you have any questions, we first want to do is push out the survey questions. And if any of those here in the room have questions for Dr. Kane, we can ask them while the survey questions are going out.
I have a question. Yeah, I don't know if it's on or off. Push the button forward. Okay. Hello. Yeah. My question, Dr. King, you talked about walking in reference to exercise, and you were saying that walking, I guess, is not the best form of exercise that she was talking about. And to me, walking is the best form of exercising. And especially as we get our age, I mean, walking is good. I walk approximately 7 miles a day. It's what I walk. And I just think, I don't know if my heart rate gets up to that point, but you talked about walking, and I would like to disagree or have a different opinion about walking and exercising. I mean, any form, if you move, it's beneficial if you do anything. Right?
So, but I'm going to interject for 1 second. But remember what I started out with: inactivity versus activity. And then and I'm not going to speak for him, but the point is, it's going to be phases of activity. The objective here is to get people. What do you say you do? Walk. Get people moving. Get people participating in the activity. Dr. King, you have anything else you would like to say?
course. What's your name? sir?
Terry.
Harry, very good question, a very good comment. If you don't mind, let me share the last slide in my slide deck because I wanted to mention that to really address because please don't get me wrong, walking is very good. But what I was saying is we are talking about some of those benefits. And then from many researches, we found out that certain intensity of exercise is necessary to improve your health. You could do, I mean, we are talking about not just walking or aerobic exercise, we're also talking about resistance exercise too. But there are intensities. If you're just lifting like a water bottle or even like this mic, you can do it, right? Really light, but it doesn't give you enough stimulus to your muscles, right? Similarly, if you're walking, it's much better than sitting down or lying down, physically inactive. It's very good. That's what I was saying. But because this is super important, I just really want to highlight. You have to go all the way to the back because please bear with me because it's a very important topic and thank you so much for bringing it up. So what I was gonna say is it's more like feasibility at first. So I put it here, if you're completely inactive, it's just important to be important to just avoid inactivity. So if you can avoid inactivity, then you can move on to be more active to you can be in this kind of not sufficiently active phase, right? So we kind of identify these people who are doing, for example, like even less than 30 minutes of walking or moderate exercise a day, and also some resistance exercise. We think that they are not sufficiently even active if even they do some of the moderate exercise, because to be able to get those benefits I mentioned in my slides is across many studies, we found out that certain amount and certain intensity exercise seems to be necessary to get those benefits. And then there are different studies we have found that this is consistent in multiple studies. But again, my mom, she doesn't have cancer. My father is a prostate cancer survivor as well. He's in South Korea. He was diagnosed in 2015, and he's also diagnosed with lung cancer. Now, after the diagnosis, he's been walking about 20,000 steps a day. My mom, she's also very active. She's have hypertension and hyperlipidemia, but she does 30,000 steps a day.
30,000.
You know, in terms of managing her hyperlipidemia and a little bit of hypertension, that was really beneficial in terms of, but she does some of the higher intensity exercise as well to manage her high blood pressure too. So just kind of really in short, walking is good.
I'll just add, I started my walking program about 18 months ago because of my A1C. Through my walking, I'm down 50 pounds. I lost 50 pounds.
Yeah.
I dropped my A1C from a 8 point something to a 6 point something.
Absolutely.
Some benefits of walking, that's what's a result of me walking.
Yeah, I believe you. Yeah, that's.
I got a question. You mentioned bike riding?
Yeah, but-
Stationary bike?
In terms of the studies we have or
Yes,
in general? Yes, it's the studies we have, they are all stationary bike. You can be given at home.
Now don't the stationary bike or any bike you ride, it elevates your PSA.
Right.
So how is that good?
Thank you.
I
Good
think
question.
Danny. Okay. So that's actually the question I sent you. One of the frequently asked questions I was gonna mention. So with the bike or any type of exercise, even walking or running, it'll increase PSA. That's for sure. But does it impact? Is it from your cancer progression? Likely not. Because exercise, and think about it, exercise does some of the mechanical, it's not just physiological, it's also mechanical. With the bike, your prostate is touching the seat. With the exercise running, it can also touch your prostate. And there's a chance that it may increase the PSA level instantly, but it's likely to be short term. And most importantly, it's not likely to be because of the cancer progression. After 72 hours or 48 to 72 hours, your PSA level will go down to normal, even after this exercise, and it'll stay the same. So that's the answer I can answer for now.
Any more questions?
Yes. You had there something on obese. I think that's very important. And of course, the exercise situation here was now you have equipment to go to the home. But also, if you're, well, I'll do it this way. In my house, I have 13 steps. In the morning, I go up and down them steps 3 or 4 times. And I do that for a main reason. I've had some constipation problems. By doing that, I've found that constipation problems are no more. Yes, exercise, I improve 100, 200, 300. That's one of the great things we need to do. Thank you.
Thank you for sharing. That's awesome.
All right. Does anyone else have any questions? All right. I want you to give Dr. Kane a good PHEN toss. And again, I wanted to thank everyone here. We have a big crowd. And also, I want to thank again our sponsor, all of our sponsors. I want to thank all of our sponsors, and then also I also want to bring up Tom so he can close out.
Thank you, Dr. Crawford. I just want to echo what Dr. Crawford said. It's great to see all of you this evening. Some of you I haven't seen for a while, so it's good to see you. And good to know that you, some of you are exercising. You know, this was a great presentation. I'm going to really use the equipment that's available to me and start an exercise program because Dr. Kane, I think, provided some great information. So, in fact, Dr. Kane reminded me that we spoke about this exercise initiative some 3 years ago. So it's good to see the progress that he's making here at Dana-Farber. And it's the type of information that we want to continue to bring to the people who tune in to PHEN, our network members and others, because managing survivorship is so critically important to all of us. And, you know, we can get a lot more out of life if we understand how to manage survivorship. And things like diet and exercise are very, very important. And I also want to thank Dr. Jim Smith down in Virginia for his presentation about those treatment options for castration-resistant prostate cancer. We'll bring Jim back on that topic again, because as Dr. Crawford pointed out, there's a lot of information there. We really want to go through that information so that you clearly understand it. But again, for those online, thank you for joining us. I want to join Dr. Crawford in thanking our sponsors. And for those here today, thank you so much for being with us tonight. And we will see you next Wednesday on the next second Wednesday during the month of June. So thank you and good night.